Welcome. Welcome back to this session. I hope you've all had a fantastic morning so far. And I have a great privilege this afternoon to bring Atul Gawande to us from Boston, Massachusetts. Atul is a surgeon, a general and endocrine surgeon from the Brigham and Women's Hospital and the Dana-Farber Cancer Institute in Boston, and he's associate professor of surgery at the Harvard Medical School and associate professor in the Department of Health Policy and Management. Atul is probably best known to many people beyond this room as an amazing writer for the New Yorker magazine. And he has translated some very complicated healthcare issues into an understandable way to think about improving healthcare, not only for doctors and nurses, healthcare leaders, but for the general public. And more people, as I'm traveling around the United States, will say, "Did you read Atul's article about this or that?" than any other health literature I've ever known. He's also been researching safety for the last several years and is the director of the WHO's global campaign to reduce surgical deaths from 2007. Atul was a senior health policy advisor in the Clinton presidential campaign and in the White House from 1992 and 93. Atul Gawande is one of the pioneering leaders in improving safety across the world and a wonderful friend. I'm so delighted to introduce Atul Gawande to us. And Atul's going to talk to us for about half an hour or so. We may have time for one or two questions. But I think that once Atul starts to speak, you'll feel like he's right in the room. So, Atul.
Maureen, thank you. I'm so sorry not to be there in Amsterdam, but instead talking to you from outside our operating rooms here at the Brigham and Women's Hospital. But it just was so tremendously exciting to be asked to have a chance to talk to you. And I can't thank Maureen and the team enough for including me. The reason I wanted to have the chance, and I'm delighted to have the chance to talk to you, is because you're a group of people that understand what our struggles are in healthcare and in medicine as we are faced with needing to tackle the goals of both improving the quality of care at the time that the economies around the world are in struggle, and there's real demand for healthcare to also control its costs. What you understand is that the deepest struggle that we have in healthcare is not actually over the dollars, and it's not over the problems of regulation and bureaucracy or the ways that corporations influence medicine as well. All of those things make our jobs difficult in healthcare, but our deepest struggle day to day turns out to be how we deal with the increasing complexity of what it's required to be great at what our jobs ask us to do. The best way I can articulate what we're struggling with is by trying to think about where we've come. And over the course of the last century, what science has been able to do is enumerate for us the number of ways in which the human body fails. And what we've learned is that there are now more than 13,600 diagnoses, 13,600 different ways the human body can fail, according to the International Classification of Diseases. And that list is growing as we develop an understanding of the genetic subtypes and so on. And for each of those conditions, we've now been able to generate solutions, if not to cure, to improve people's lives, to reduce their suffering, improve their ability to live long, if possible, and also simply have a quality of life that allows them to prosper despite illness. But what does that list of capabilities require? It's now 6,000 drugs that a physician can prescribe, 4,000 medical and surgical procedures that our teams can perform, and countless ways that we haven't carefully enumerated even, that we have for being able to prevent illness and disease. Now, what our job has evolved to be is deploying those capabilities to take care of 13,600 different conditions, and deploy them town by town to every person alive. Do things in the right way, at the right time, without waste of resources. And as we've tried to do this, we're discovering that there is no industry in the world that has ever been asked to deliver on 13,600 different service lines to every human being in the world, in every town in the world. And guess what? We're finding it hard. It's incredibly challenging. You go a little further and you realize the complexity has increased even more, because there's about 5% of our patients who account for 50% of our work and 50% of our costs. Because guess what? People don't come with just one of those conditions. They come with multiple conditions and often are made very sick by the combination and require even more customized care in order to deal with the diabetes and the cancer and the rare eye condition that you may not even know very much about. What I've come to realize is that we were fooled, I think, by penicillin. And we are struggling with a legacy that has been set by the ways we've thought what advancement in medicine would mean. When I say fooled by penicillin, I mean that in 1929, when penicillin was discovered at St. Mary's Hospital in London, and then when we learned how to distribute and manufacture penicillin in mass quantities, it began to be received upon the world as this incredible miracle. And it was. And I think it was for two reasons. Number one was it could cure diseases, a whole range of diseases that we didn't think we could do anything about. Didn't think we could do much of anything at all. And then the second thing that made it a miracle was that it was so easy. It was just an injection. And it made us think, this is the future of medicine. Discovery would be the hard part, but execution would be easy. We imagined that there would be an injection for cancer, an injection for heart disease, an injection for strokes. And we built medicine around a few kinds of treatments which could be managed in a doctor's office with a small team, not even really a team. Could be managed if you added in a capability of a workshop like a hospital or an operating room for that lone physician. But what we've come to discover today is that the enormous complexity of what we've been able to do looks a lot more like delivering operations than like giving people just a simple injection. And individual physicians, it turns out, just can't do it. The volume of knowledge and the amount of work and the complexity of what has to be done that's required by modern medicine is more than an individual clinician can do or hold in their head on their own. It is now a world that requires organizations and systems, and we have not yet been able to come to grips with that. Part of the way we know it is from our failures. Studies in the United States and abroad have turned up what the troubles are. For example, more than 40% of people with not pneumonia, but with heart disease in our communities receive incomplete or inappropriate care. It's 60% of those with pneumonia or asthma or stroke. And if we consider severe mental illness, the rates of incomplete or inappropriate care get up to 90%. Now, in the midst of our struggles in all of our countries with the costs of healthcare as well as the safety and quality of healthcare, the puzzle that we each have in our work is where we want to make the biggest difference. Outside of the operating room, I've asked myself this question and ended up finding myself in a kind of work I never expected to be doing, not remotely. I write, and that was a surprise. But as much as that might get a high profile, where I spend the majority of my time these days is on, of all things, checklists. And I didn't ever imagine that this would be what I would need to be working on or think might be the way we make a big difference. But it appeals to my simple-minded nature as a surgeon, which is, what do we as clinicians want to actually do next week that would be different, that would make us great at what we do? And then we want to build our system, our structures, our financial incentives, everything, to fit what that requires, what we would actually be doing differently and how to foster that. And I'm going to turn to the slides because I want to talk about an example of this. The World Health Organization gave me the chance to think about how we might try to do something better when they asked us to be involved in a project to reduce deaths in surgery. It's interesting that it became that they were even asking, because this is an organization that focuses on issues like childbirth and malaria and TB. But as we dug into the numbers, I began to find out why. And what we've seen now is that the volume of surgery worldwide, as the populations in the world have aged, the demands for complex care for everything from cardiac disease to cancer, which is now in the top 10, to road traffic accidents, which are in the top 5 of major killers in the world, that the demand for surgical care had reached the point that the volume of major surgery had now eclipsed the volume of childbirths in the world, but with death rates 10 to 100 times higher. And suddenly making our systems of care just in surgery alone safe had become a major public health necessity. In order to do this, what we had to think about was our strategy. The usual ways that we try to improve things in medicine is by training, and so we train longer and longer, and technology. But that had not been able to succeed. And so we began looking at examples across medicine, and people at IHI, people at Johns Hopkins and other places had begun to look at other industries like aviation and started understanding lessons that there was the possibility of using checklists of all things to improve the management of complexity. We think of checklists as something that's about dumbing things down for the people at the bottom of the totem pole. But what we actually see in industries like skyscraper construction, aviation, even how gourmet kitchens work, is that the checklist is often what you put in the hands of even their most high-end professionals to improve their performance under conditions of complexity. Under conditions of complexity, you can't remember everything. And so a well-designed checklist like this one for the takeoff of an airplane is brief and simple and make sure that the key points are hit for being able to execute well. And so we decided to try applying this in surgical care. We involved Boeing to help walk us through the process of making a great checklist. It involved needing to analyze the failures in the processes of care, something we don't often do. Actually boil down and look at what we see at the front lines as the most common ways that the care fails that are harmful. Then to identify pause points, that is moments in care when you can pause and make checks. And then identify best practices to avert the key failures for each pause point. People know these at the front line. There is often hidden knowledge of what needs to be done, and there's often information in the literature that simply hasn't been brought to the front line. Then it must be distilled into a practical checklist, and what you discover when you first try it is it never works. You have to try and try again. We've not been able to make a checklist that was actually usable at the front line in an effective way in less than 50 redrafts. But after going through this process, what we found is the ability to put checklists together was complex enough that we needed a checklist for checklists. They'd even discovered that the font you use can matter under conditions of stress and complexity. But following what they helped us understand, we designed a checklist for surgery with 3 pause points. A pause before the moment of care, a pause before induction of anesthesia, before starting anesthesia, a pause before the skin incision, and a pause before the patient leaves the operating room. And at each point, we distilled checks that could be done in a minute or less, trying to stick with the high priority kinds of items. Things that included some dumb checks, like making sure that we didn't forget the blood that might be needed for a high-risk operation, that we're operating on the right side of the body, that we given antibiotics in the right time window. But then there were also interesting checks, making sure everybody had been introduced in the room by name and role, making sure that they'd spoken, the surgeon, about the goals of the operation, how long the case would take, what the team needed to be prepared for. Anesthesia discussing the medical issues of the patient, the nursing team discussing any concerns they had about equipment, sterility, or otherwise. We implemented this checklist in 8 hospitals around the world, and we deliberately chose places ranging from top highly resourced centers like Toronto General Hospital, St. Mary's Hospital in London, University of Auckland, New Zealand, University of Washington in Seattle, but then also low-income places, rural Tanzania, a Crush City Hospital in New Delhi, Refugee Hospital in Amman, in Manila, Philippines, one of the busiest trauma hospitals we'd seen. And what we found was that in every hospital, the rate of complications was reduced with adoption of the checklist. The average rate of complication reduction was greater than 1/3. The reduction in deaths was 47%. The results were initially controversial. Some places adopted the checklist, like the United Kingdom, Ireland, other countries. Others were concerned that there was no control group. There was not, and they'd included a range of places that were from rich to poor, and it wasn't clear which ones were driving the results. We did find that the complication reduction was over 30% in the high-income hospitals. But then, just in the last couple of months, some really important studies have come through validating that this approach is crucial. Right where you are, coming out of the Netherlands, was the SURPASS study, which took the checklist-based approach and applied it in the Netherlands with a strong control group, and found almost eerily identical results, a 1/3 reduction in complications in the hospitals that adopted compared to controls, and a 47% reduction in deaths. A further study published in JAMA around the same time last fall showed that in the Veterans Administration System, this approach could be scaled to 74 hospitals across an entire country, with a 18% reduction in mortality compared to controls. We've seen this work spreading, and what it shows us is that simple solutions can save enormous numbers of lives. This is now spread to 4,000 hospitals. But we've also seen that there is resistance. There's difficulty, not just in coming up and being willing to test and create such solutions, but then in being willing to try them. And part of what needs to be grasped is that implementing these kinds of solutions is not about just putting a piece of paper up in an operating room. We've seen in places that have adopted the checklist that if you don't have an understanding that this is a culture change, there can be great difficulties. The most fundamental thing we've recognized is that there's a process, It mirrors a process that IHI has taught all along. First, to engage an entire group of people with a system that must be prepared even for something as simple as trying a checklist, including, in this case, surgery, anesthesia, nursing, and management personnel, because often there are systems issues that need to be cleared in order to make it possible just to make the 19 things on the checklist actually happen in a hospital anywhere. There needs to be education with training for staff. In this case, at least a half-day training with a chance to practice and make sure that people know how to do what needs to be done. And then when there's execution, to start small with one unit, one operating room, before spreading to others and making sure you make it work step by step. And then finally to evaluate, to be able to follow up afterwards and check and see, has the approach worked? There's a set of values at work when you take on a job like this. This isn't just about surgery. This is about defining, in whatever line of clinical work we're doing, what it means for us to be really great at what we're doing, what we want our teams to be able to feel like. And when you try something like a checklist, just use it. What I've come to realize is that there are a set of values that you are expressing when you do this. And not everybody shares those values. And that is the deepest source of emotional resistance here. The values that are contained in a checklist are humility, the willingness to recognize that no matter who you are, you will fail at what you do. Your brain will not hold it all. And an aid like a checklist can help. The second is the belief in discipline. The value that you understand that trying to standardize certain things, make things go the same way every time, can be crucial to your ability to customize at the crucial moments in care. And the third is the belief in teamwork, an understanding that another way that you can be saved and therefore your patient can be saved is by understanding that the people around you will be crucial to saving you. It's just one seeming small step, I know. But as we look more widely at our systems of care, what we're going to realize is that to make the key processes go well, these are the kinds of steps we're going to take. In field after field, we will find it will save people, it will save costs, and it will save lives, as well as our system. I got a letter not long ago from a patient named Dwayne Smith from Texas. He's a 34-year-old grocery store manager who was in a terrible car accident when his car hit another car head-on. What the teams did to save him was amazing. He had a broken leg, a broken pelvis, broken arm, bilateral collapsed lungs, and internal bleeding. And from the moment the EMTs took care of him, got him to a trauma center, got him from the trauma center to the operating room, everything went beautifully. They were able to stabilize his fractures, get chest tubes to inflate his lungs, get him to the operating room swiftly to explore where the bleeding was coming from, and they found it was from a splenectomy. They needed to do a splenectomy because of a ruptured spleen. He spent a couple weeks in intensive care, then a long period of rehabilitation, and at every step along the way, things went just about how we'd want it to go. But there was just one tiny step they missed. And as proud as they were of what they had done, for him, he was grateful, and yet that one step changed his life. They'd forgotten to give the vaccines you need to give for a splenectomy. And the result was that a couple years later, because he didn't have his spleen and he didn't have the vaccines, he got an ordinary strep pneumonia infection that you and I would handle with an antibiotic, and it spread throughout his body, causing sepsis, and then ultimately, as you'll see here from a picture of Dwayne, the loss of all his fingers and all his toes, loss of his livelihood and his means to survive. The damning thing about his story is not what happened to him. The damning thing is that none of us learned from it. For exactly this kind of failure has happened in my hospital, and I guarantee it's happened in your health systems. We miss this kind of unglamorous step, I'd say probably half the time. And it's for the absence of a simple set of checks. In this case, at the end of an operation with the checklist we've designed, the team simply asks itself as a group, is there anything we've forgotten for orders for the patient before the patient leaves the operating room? And that's the moment when he could have been saved. That's the moment when you could have saved him. Thank you.
Atul, thank you so much. I wish you could be here to see. There are thousands of people staring at you and taking notes, and I think making silent pledges to begin to use the checklist. Just one quick question before we wrap up. What's next on the checklist horizon? You talked about surgical checklists. Are you working in other areas as well?
Yes, Maureen, I'm delighted you asked. You know, and we need other people working in these areas. I mean, I think in emergency medicine, in internal medicine, other fields, these can make a difference. As you know, NIHI has worked on, Peter Pronovost and others are working on central line checklists. There's teams in Michigan working on and delivering a checklist for urinary tract infection. We've got a checklist we're now testing in India for childbirth improvement, a safe childbirth checklist in a project with the World Health Organization. And also starting a project for a checklist involved in the care of people with terminal illness to improve our palliative care and end-of-life care discussions. I don't know how far we can take this. The core concept of saying that there are and that by conducting our process in simple ways. I think that is absolutely crucial. It is something many people have observed, and you as an audience can help us deliver.
Thank you. Thanks so much, Atul. We just had a little bit of audio trouble in that last, but I know that I've spoken to Atul about this before, and when he's talking about implementing checklists, some of the resistance that he says it goes away when he says to a physician or a nurse, would you want to be operated on without a checklist? And he said invariably everybody says no. So thank you so much. We have now a almost impossible task, but in 15 minutes time we have a special live broadcast from the Fukushima, Japan team to help us to understand what's really happening on the ground there. So Professor Shigatsu Hashimoto from the Fukushima University Hospital and Ryuki Kasai, community doctor in Fukushima, will be joining us in just 15 minutes. So what I need you to do is to go out and grab your lunch if you want to. Bring it back in. You can't eat in this auditorium, but you might want to get your lunch, take a very quick break, and then we start promptly in 15 minutes. So thank you very much, and thanks to Atul.